So Dr. Quinn, we've got the ZoneRX there. And is this one of your patients?
Yes, this is one of my favorite patients. He's never complains. And he's very generous about allowing me to use him as a model. So what happens...
Let's come over here a little bit so I can...
Okay.
I can just position this so I can see this a little better.
Okay.
So hold on just a second. Let me get the... Okay, great.
Okay, so what happens is that by design we have the big liver right here.
Okay.
Okay. And then we have the heart up here. This is a big heavy organ. This is also a big heavy organ. And there's all this connective tissue that has to support them. And you have this big diaphragm muscle that goes all the way around and attaches to the spine. Because this organ is so big, relatively speaking, and dense, and this connective tissue is bigger and denser, as it if we're not moving, then gravity starts to have an effect, and basically we start to tighten up and compress around this. We literally torque and twist around
the extra cura fibers pulling on this rib cage,
yes,
kind of pull it and pull you in a torque fashion.
Pulls you around.
If we were active running 20 miles a day chasing down our food, this is all designed to be counteracted by these extra connective fibers.
Right.
So what happens to the ilium as we fall out of alignment?
Well, they go in opposite directions of each other. This one falls forward, this one falls backwards. So the reason that happens is because if we think of this as being very heavy and pulling down, to compensate and offset that, this ilium has to go backwards.
Okay, so this is the SI joint in here.
Correct.
And so you get actual slipping on that joint?
You do get pinching in here. So as this one goes back, this one comes forward, and that's what we see clinically, is that people rotate clockwise. This goes forward, this wedges out. Okay, this goes back, and this wedges in.
And so when they're trying to walk, now their hip flexors are tightening, trying to pull them back into alignment because they're walking crooked.
They're walking crooked, and their femurs are being pulled. And so what happens is now that people have to maintain an increased postural tension to keep them at neutral. So it's very common to have tension in these hip joints and in the lateral.
And then your flexors here, which are pulling on the low back. And
right.
But what's happening with the rib cage in the same process?
Okay, so the rib cage comes down on the right and opens on the left. So you're like this.
So you've got a shutters closed here.
Correct.
Shutters open. Kind of.
Right. So this pulls up, so you get shorter on the right and longer on the left. And I see that, and we all see that clinically a lot. This pattern is very, very common.
The diaphragm's coming up here in that upside down J shape.
That's right. And what happens is that because the diaphragm is attached to the spine, when this is in spasm, which it is, trying to stabilize this, it causes hyperextension in the lumbar spine, which has negative consequences on the facet joints. Also has negative consequences on the discs, because now you have a prolonged compressive force on the discs, which accelerates the tendency for degeneration and dehydration.
And so when the diaphragm flattens out, it can't pull the lungs open anymore.
That's true.
So then the patient's starting to use their
scalene muscles, their upper...
To breathe, just to breathe.
Just to breathe. They're using these muscles now to breathe.
They're using their neck muscles to breathe.
That's right, which is going to facilitate head forward posture. So everything's interconnected.
Okay, so that's where the head forward posture comes from.
Yes, a lot of times. Plus sitting at a desk all the time.
So they often get too much curve in the low back.
Correct.
Maybe not a military neck up here. Head forward posture, using the neck muscles to breathe, because the diaphragm with every breath can't pull the lungs open because it's flattened out.
That's right.
The ilium have fallen forward and are torqued. The chest is inflated.
Yep, and it's compressed on this side, open on this side. It absolutely affects the breathing.
So that affects the range of motion of shoulders?
It will, because part of this pattern of compensation is that now the right shoulder is going to become depressed, tends to go anterior, and so the whole body is torquing. So what we call this a scoliotic tendency.
Mm-hmm.
Okay, so depending on a person's history and their genetics and their lifestyle, that tendency can manifest in various ways. Okay, it can manifest into scoliosis for some people, but that tendency is there nonetheless. For some people, it's Facet syndrome.
Mm-hmm.
For some people, it's piriformis syndrome. For some people, it's SI problems.
For some, it's the shoulders.
That's right, because it's depressed and anterior. You could develop thoracic outlet syndrome.
But they're certainly, if they're not breathing properly and having to use their neck muscles to open up their lungs with every breath 24,000 times a day, they're probably not as oxygen or energized, oxygen-rich environment as you would like to see.
That's right.
So when you get them breathing properly, you mentioned that part of the procedure here on the ZoneRX
Yes.
is to have them breathing deeply.
That's right.
In part of your plan of care, you use this non-medical device, this exercise device,
Right.
to help them target the muscles that fall into disuse and are underutilized on this.
Yes.
In this situation.
Asymmetrical. Part of the muscles are working too hard, and some of them are underworking. And
So you try to inhibit the ones that are working too hard
That's right.
and strengthen the ones that have atrophied.
That's right.
And you do that by teaching the patient which muscles to fire. When they fire them, these sensors and lights alert them that
That's right.
they're in the zone, so to speak.
That's right. So when they go into the posture that turns these lights on, they are turning on the muscles that are weak and allowing the muscles that are working too much to start to relax.
Mm-hmm.
So we call that inhibiting the over-facilitated muscles.
Okay.
And it's really an education process for the patient. They are doing the work.
What about for the clinician? Would you say that this is labor-intensive hassle, or what kind of work is this for the clinician?
There's actually, once you spend a few moments explaining it to the patient, like 5 minutes, they get it pretty easy. That then they do this themselves, then we have them walk, and then we have it doing it. This is not labor intensive. They're doing most of the work, getting feedback if they're from the machine, if they're doing it properly. And the thing that I like the most, because it really boils down to this. This theory is great, this is accurate, it's true, but take all that away. What's most important is that it works consistently.
Do patients get it? Do they understand this is the first time someone's actually dealing in 3 dimensions with me and working with the torque around my spine?
I've had people call it magic after one.
Call it magic.
They go, this is like magic. My pressure, my back, my hip feels loose now. How did that happen? I said, well, we untorqued you.
So is there advantage having the machine do it where the machine doesn't act upon them, but it's only the patient's own muscle activity pushing against it? What's the advantage of that?
Well,
compared to being adjusted?
Right. Well, adjustments certainly have their place. However, it's very important to have the muscle component in as neutral as possible. Therefore, any adjustment that's made is, first of all, going to require less force, and it's going to last longer.
I see. So this is not competitive, but complementary to adjustments as a healthcare provider who has that skill set. But when the patient gets on this machine, they're basically repositioning their body against the sensors, and like this arm here, if they push against it,
that's correct.
Then the light comes on here.
That's correct.
And so it's just guiding them to how to position their body, but it's all their own active muscle activity.
This is a type of active therapy, absolutely.
So this is what's
active therapy,
and it requires that for patients to form new neurologic patterns.
That's right.
to overcome the ruts in the road, so to speak, that they keep falling back into, how they hold their body, how they fall into the head forward posture, and to overcome that, you're saying requires active muscle activity in their own body.
That's right. Oh yeah, okay, so going back to your other question. Okay, when I first got this, I used it, but I didn't use it as much as I use it now. And the reason is that I basically had to test it for myself. I was doing a lot of these positions manually myself.
So you would use your upper body strength and have the patient push against you.
Right, exactly right.
And do what the unit does in an automated format.
Right.
You're using protocols to have the patient push against.
That's right.
And were you getting results using those protocols?
I was, but this is what I found. First of all, this is what I found. It was quicker and more profound change when they did it with this versus me doing it manually on them.
Why would that be? Were you surprised when you started putting these hot discs in patients in pain that you wanted to baby and do first manually, try to mimic what the machine did, and then you found, okay, I have comfort with the machine now, I'm going to put them on this targeted exercise device.
Well, at first
were you surprised when you saw that the patients were responding even quicker?
Yeah. My first thought was, well, maybe it's going to be too much on them. You know, they're acute. Subacute. Maybe it's going to be too much. So I did it manually, very gently, very slowly.
How could it be too much, though, if it's the patient's own muscle?
Well, that's what I had to learn, that it wasn't too much.
It wasn't too much.
Right. I had to learn that. I had to decide that for myself.
Mm-hmm.
Because I can control how much I can do on a person. I didn't know what they were going to be able to do on their own. But what I learned, comparing the two, is that it is safe for someone acute to do this because ultimately it's working on a deeper level than I can initiate for them. They're engaging their whole body
simultaneously.
More than I can do.
So the lights that come on when they use specific muscles that tend to get underutilized, that's helpful in educating them they're getting in the right position.
Right.
And so as a clinician, how many years have you been doing this?
26.
26 years. Have you looked for some way to deal with this dimension and deal with the pelvis, the whole spine rests on in those years?
I have.
So do you feel that we've plugged a hole that has been missing in your practice, or what? What's your...
Yeah, definitely. Boils down to this. I've always had a sense that there was these patterns, okay, but I wasn't really sure how the dots connected.
Can you give us an example of a patient? I thought I heard you mention a 82-year-old that came in recently.
Yeah.
What was his situation?
Well, he came in for peripheral neuropathy, and I have him on a home care for that. And as part of my protocol, I have him come in once a week for some basic body work, some myofascial, some range of motion. And in the course of me starting with him, he started to develop some low back pain unrelated to what I was doing. It just came about. So he went to his primary care, which was a reasonable thing, and they sent him for physical therapy to do exercises. And the exercises absolutely flared him up.
Were they exercises or stretches, or what were they?
A little bit of both. And
okay.
It was just miserable. And he basically was told...
So his body's saying this hurts, and they're saying no pain, no gain.
Exactly right. He said, well, maybe if I just do it more, I'll work my way through it. I said, well, okay. We have the luxury of knowing what doesn't work, so now let's try something different. So I did a combo on him. Because he was so acute, and then he was 82 years old, I said, okay, I'm going to do a few manual things. I'm going to do a few stretches and range of motion. He tolerated that fine, based on the principles of what this machine does. Okay, brought him out here.
So you used the ZoneRX protocols. Okay.
Exactly right. Manually, not for very long. Basically, it was a tolerance test. Okay, put him on here. He went through it. Later that night, his wife called and said that he felt great. His back pain essentially was gone. after one visit, okay, and this guy is highly deconditioned. Okay, he was very big in the front.
How long had he had that back pain that was now gone?
Well, it had been chronic for a long time, but this was an acute flare-up.
This is his first visit,
Right.
first treatment.
Right. It was facet syndrome is what it was.
So you reposition him, but you haven't strengthened it yet or stabilized it.
Correct.
But often, do you find patients see immediate benefits?
All the time.
All the time.
All the time. Because you're taking the pressure off those facets. You're taking the pressure off the SI joints.
Do
the
patients,
hip joints.
does this message of a three-dimensional torquing, does that resonate with patients? Do they get it?
They do.
When they get on the machine, do they feel it? Do they look at you and say, wow, something's happening that's different?
What they realize is how challenging it is to get all the lights going on at first.
They see the lights going on
Right.
when they're using certain muscles.
Right. But they go, wow, this is harder than I thought because it doesn't look that hard. You lay on it, you push a few spots. Those grooves are so ingrained in their neurology that they can't even consciously, at first, necessarily turn them all on. They have to start.
It's very difficult to get all these lights going at the same time for the
It is.
patient.
And I tell
Once
people,
they get it, it's like awakening them to the postural neutral they need to be in.
right. And then we
So
can
it's an
teach them.
educational process.
Absolutely. And then we teach them. Then they say, well, how should I sleep? Or how should I sit? Or they say, okay. And then we give them things to do at home that they can keep neutral. So this like activates that. And then we empower them with some other information to help maintain it. So this is the kind of like the like the rust, in a lock. This is breaking loose that rust in there.
Interesting.
And the tumblers are falling into place.
Forming the new patterns,
Right.
getting back to postural neutral.
Right.
So what are the types of applications that you would see patients? First of all, what percentage of patients that you've seen over the years do you think were out of postural neutral?
All of them.
It's amazing.
Yeah, all of them.
And you've had to manually address that until now.
Right.
How long does it take on this machine for a patient to get on and do the targeted exercise that pulls them back into that?
You could do, after the 5 minutes, less than 5 minutes of talking to them, they could be done with this in 10 minutes.
10-minute treatment.
Yep.
So they can climb on, climb off. It's a tilt machine. So do you, when you're adjusting these patients, do you line up the feet so that they're equal? And you use the little
Yes.
numerical readout
Uh-huh.
to line those up perfectly
Yes.
with each other? Okay. And so you adjust these sensors to push on the knees, but you really have to adjust the feet and these sensors.
Exactly right.
You keep the feet to the square.
Correct.
Once they set on, you put this other, for the left knee, this is another sensor. The patients, when they push it,
Yep.
the light comes on.
They're untorquing themselves. They're untorquing their femurs relative to their
So
pelvis.
here you are pushing both knees,
Exactly right.
and that's where the lights come on. Okay.
That's right. So basically, you're untorquing the left side because the left side tends to pull around. So
So when they pull with their heel on this left heel, that
they
tends to untorque.
engage their
And
left hamstring.
engage muscles that tend to atrophy on the glutes and the
hamstring. So you're pulling this back. You're untorquing them. So that specifically untorques them on the left side.
That's the inhibited.
Inhibited left hamstring.
Okay.
Okay. Then, so that is your sagittal plane. Remember we talked about the three planes? That's your sagittal plane. That's your front to back. Left hamstring is pulling you back this way sagittally. Now you're working the transverse plane and the frontal plane with these because you're working these muscles in here. And these muscles in here either control this side to side or this.
So it would. How much time would it take you to do this manually with a patient?
Well, it's a lot longer and it's not as deep.
Not as deep because it's you working on the patient.
Right.
So it's, in some sense, they're passive even though you tell them to press against it. But the machine, it's all active patient's muscles only.
That's right. They're in this. I love the term of the jig, the pattern. They're in this pattern. So if they want the lights to light up, they have to be in the pattern. and the machine is saying, this is how you're supposed to be, and if you do it right, you're going to have the lights.
And it ingrains in your consciousness where you've been out of alignment. Subconsciously, people aren't aware of how they've gotten out of
Absolutely.
alignment into these negative patterns of imbalance where their body muscles have to start tightening and going into spasm to pull them back, trying to pull them back into neutral.
Mm-hmm. Right.
And the diaphragm flattens out. So when you realign, when people are able to pull their body back to postural neutral, what kind of benefits have you seen for people? Do they breathe better? Do they get better oxygenation? Do you feel that?
Well, they're more relaxed.
They're more relaxed. And do you see spasms going away when people are back to
particularly in the right lower back, because that's where they hyperextend because of the diaphragm muscle. So the right QL will loosen up. People get a lot of spasm in here. Their SI joints loosen up. So if we were to make a greatest hits of why people come in, okay, people are torqued, but they don't manifest the same symptoms. But what can those symptoms be? Low back pain, SI pain, hip pain, knee pain, impingement, piriformis syndrome, plantar fasciitis, because their feet are compensating for what their knees and hips are doing. So they could have any or all those things, but it's all stemming from the torque.
The entire spine rests on this pelvis.
Correct.
And so it's fundamental to all of these other issues.
That's right.
And if you're out there, you're going to have it. Some people have it manifest with cervical problems or lack of oxygenation. They're not breathing properly. They're breathing with their neck muscles.
Right.
Some it manifests with range of motion problems in the shoulders. Could be tied to even carpal tunnel. And the hands could have its genesis in the neck.
It can.
Because of that. And so you're seeing all manner of different. Now, as a clinician, you're using a non-medical exercise, targeted exercise device that is totally passive, has no action upon the patients.
Correct.
But with the sensors and lights, it's able to guide patients to push their body back by pushing against it through active exercise, targeted.
That's right.
So as a clinician, you make this part of your plan of care.
Yes.
For a wide range of maladies.
That's right.
Yeah. So you said virtually all of these patients that have come to you over 26 years are out of postural neutral.
That's right.
And now you've got an automated way to work with that dimension without a labor-intensive hassle for you.
That's right.
Once the patients get it, do you let them come in and get on the machine themselves, or have one of your staff members help them get on?
Once we get them used to it, the staff can do it.
Staff can just put them on the machine, and the patients get this. They say, "Wow, something's happening here."
That's right.
Does this, from a business standpoint, give you a unique service that is not being offered?
Absolutely.
Is there anyone in this 2 million person marketplace that you're aware of addressing in such with a beautiful, totally passive technology? Is there anybody doing anything like this?
Nobody I know.
What that means is you're going to get outcomes faster, better outcomes.
Right.
And the patients will recognize that.
You know, I would be very happy seeing my patients for a shorter amount of time that are happier because they're getting results quicker. I'd rather see more people a less amount of time than the same people for a longer period of time.
A lot of clinicians are tired of being on the treadmill and doing all the heavy lifting and all the manipulating and adjusting themselves. So would you say that not only is this a patient-first kind of protocol on this instrument, but it's also going to save them a lot of labor-intensive?
It can.
You still have to have a relationship with the patients. You got to do proper intake initially.
Right.
And then...
And I still work on patients. What I find that it's easier to work on them. Any adjustments that I do.
Because you're relaxing the muscles in spasm, trying to pull them back to neutral when they're able to pull themselves back to neutral.
That's right.
Wow.
And these protocols from the ZoneRX, they're like truisms. Okay, like there's the law of gravity as a truism. You know, there's certain things that are just are. Okay, and this is one of those. So what it's done for me is I've always struggled in the past with recommending exercises for patients because it's such a kind of a big nebulous process. Working with this has clarified my understanding of where the muscle imbalances are. So now my exercise prescriptions are actually simpler, more concise for me to administer, but also for the patients to do.
Do you have to adjust the sensitivity to this back sensor that shows if they have too much curve, they try to flatten their back out against this?
Yeah, this is the one I have to adjust the most.
You have to adjust that the most. So you
Yes.
can adjust the position forward and back by simply turning this little knob.
Forward and back and up and down.
So you can adjust this to come in or out. What about sensitivity for the sensor? That's this sensor right up on top here.
That hasn't been an issue. It's basically the position of this here, which is releasing the.
But you can make it more sensitive or less sensitive by putting a little Allen wrench in
could,
here.
Yep, and that hasn't been an issue.
Okay.
It's an option to fine tune it when you first get it, but once you get it, it's pretty much set.
Okay.
So
So let's actually do a full treatment here, and we'll videotape that next.
all right,
Thank you, doctor.
you're welcome.